Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Rajahmundry, Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we are going to talk about a very interesting topic, Cognitive Neurology Part 7, Aphasia Examination Part 3. Cognitive Neurology Part 7, Aphasia Examination Part 3. Clinical Examination. The clinical examination of language should include the assessment of naming, spontaneous speech, comprehension, repetition, reading and writing. So, naming, spontaneous speech, comprehension, repetition, reading and writing. A deficit of naming anomia is the single most common finding in aphasic patients. So if you are asked to name a particular object, they'll not be able to name it. For example, if you show a pen and ask them what this is, they'll say, so I know, it is used for writing. You pour ink in it. They'll give all descriptions of that particular object, but they cannot name it. This is known as beating around the bush or circumlocution. So a deficit of naming anomia is the single most common finding in aphasic patients. So the clinical examination of language should include the assessment of naming, whether they are able to name the object, spontaneous speech, how is the word fluency. The normal word output is 100 to about 115 words per minute. Comprehension, whether they are able to understand the speech. Repetition, whether they are able to repeat what has been told to them. Reading, whether they are able to read, or writing, whether they are able to write. And a deficit of naming anomia is the single most common finding in aphasic patients, and when they are not able to name a particular object, they will be beating around the bush, known as circumlocution. We have paraphasia, a parallel but not exact word. So aphasic patients may have paraphasia. They may tell a parallel but not exact word. Again, there are two types, semantic paraphasia and phonemic paraphasia. In semantic paraphasia, which is seen in Wernicke's aphasia, they give an incorrect but related word. Example, pen for pencil. Whereas in phonemic paraphasia, seen in Bromas Aphasia, the word approximates the correct word but is phonetically inaccurate. For example, plentil for pencil. So they will have lot of paraphasias, a parallel but not exact word. Semantic paraphasia seen in Wernicke's aphasia, phonemic paraphasia seen in Broca's aphasia. Now let's talk about these individual aphasias. Wernicke's aphasia, Wernicke's area is affected. So what happens? The comprehension is impaired. Repetition is also impaired because Wernicke's area and the arcuate fasciculus is close by. So Wernicke's area gets affected, the comprehension gets affected, the close by arcuate fasciculus is affected, so repetition is impaired, but Broca's area is intact, so language output is fluent. So in Wernicke's aphasia, comprehension is impaired, repetition is impaired, but language output is fluent. There may be paraphasic errors. Paraphasic errors may lead to strings of neologisms which lead to jargon aphasia. Neologism means new word formation, coining of new words. So they have neologisms which leads to jargon aphasia, a totally non-understandable speech. The lesion being an embolus to the inferior division of the middle cerebral artery is the most common etiology. The entire perisylvian area, language area, is supplied by the middle cerebral artery, which divides into two divisions, superior division and inferior division. Superior division supplies the Broca's area, inferior division supplies the Wernicke's area. So if an embolus lodges into the inferior division of the middle cerebral artery, it affects Wernicke's area and causes Wernicke's aphasia. In Wernicke's aphasic patients, there is no hemiplegia because Wernicke's area is the temporal area. Whereas corticospinal tract comes from the frontal lobe, internal capsule, midbrain, pons medulla, and crosses over to the opposite side. It does not traverse through or cross or go through the temporal lobe. and therefore Wernicke's aphasic patient will not have hemiplegia because corticospinal tract is not affected. So there is no hemiplegia because only temporal lobe is affected and not frontal lobe, which carries corticospinal tracts. And since the temporal lobe gets affected, the optic radiations go to the temporal lobe. They'll have homonymous hemianopia. And if the parietal lobe gets affected, they'll have inferior quadrantonopia. If the temporal lobe gets affected, they'll have superior quadrantonopia. So they'll have homonymous hemianopia, especially the superior quadrant gets affected, which is known as superior quadrantonopia. And in these patients, vernix aphasic patients, they are not depressed because they don't even realize that they have the deficit. They have speech problem. So they are not depressed because comprehension is lost. So vernix aphasic patients, they are happy patients. They are happy patients because they do not know that they are having disease, and they do not have hemiplegia because only temporal lobe is affected and not the frontal lobe or the corticospinal tract area, and therefore they will not have hemiplegia, and they'll talk fluent but nonsense speech. A fluent nonsense speech without hemiplegia and persons being happy. So onlookers and bystanders think that these persons are having psychiatric disorder because they don't have any neurological deficit other than talking irrelevantly, and most of the time they land up in psychiatric hospitals. But actually when the CT scan is taken, it shows clearly that the vernix area is affected and it is vernix aphasia and it's a neurological disorder. So this is vernix aphasia, a fluent but nonsense speech. Next we have the Broca's aphasia, wherein the Broca's area is affected. It is non-fluent. Generally the normal word output is about 100 to 115 words per minute. It may be reduced to as low as 10 to 15 words per minute. But they have sensible speech with impaired repetition. So it's a non-fluent but sensible speech. The repetition is also affected because the arcuate fasciculus is close by. The cause is most often infarction of the Broca's area, that is in the inferior frontal convolution, due to the occlusion of the superior division of the MCA. So the superior division of the middle cerebral artery supplies the Broca's area, inferior division of the middle cerebral artery supplies the vernix area. So if an embolysis lodges into the superior division of the MCA, it affects Broca's area and causes Broca's aphasia. Here, the patients will have hemiplegia because the corticospinal tract is involved, because the corticospinal tract travels in the frontal lobe, and therefore they will have hemiplegia, and they are depressed because the inside is good. They know that they are suffering. So it's a non-fluent but sensible aphasia. They will have hemiplegia, and they are depressed because they have insight. And patients with Broca's aphasia, it is non-fluent but sensible speech. For example, if you ask what's your name, they'll say, for example, their name is Mr. X. They'll say my name is X. So it's a telegraphic. Main words are used, non-fluent but very sensible speech. That is Broca's aphasia. When the cause of Broca's aphasia is stroke, recovery of language function generally peaks within 2 to 6 months, after which time further progress is limited. So most of the aphasic patients should be able to recover within 6 months, and if God forbid if they don't recover before 6 months, the prognosis is usually bad for recovery. Conduction aphasia. Here the speech output is fluent, comprehension is intact, but repetition is severely affected. Vernix area is responsible for comprehension, arcuate fasciculus is responsible for repetition, Broca's area is responsible for fluency. So if arcuate fasciculus gets affected, repetition is severely affected, what we call it as a conduction aphasia. So speech is fluent, speech output is fluent, comprehension is intact, but repetition is severely impaired. The responsible lesion, usually a CVA in the temporoparietal or dorsal perisylvian region, interferes with the function of the phonological loop interconnecting Broca's area with vernix area, that is the arcuate fasciculus. So as long as arcuate fasciculus is intact, repetition is intact. Transcortical aphasias, these are repetition sparing aphasias, because arcuate fasciculus is intact and the lesions are distal and disconnected. So transcortical aphasias, the arcuate fasciculus is intact and therefore the repetition is intact. They are distal lesions. They are very much far off from the arcuate fasciculus, and therefore as the arcuate fasciculus is intact, repetition is intact. We have two types of aphasias, transcortical motor aphasia and transcortical sensory aphasia. These are repetition sparing aphasias because arcuate fasciculus is intact and the lesions are distal and disconnected. Transcortical motor aphasia and transcortical sensory aphasia are similar to Broca's and Wernicke's aphasia, but repetition is intact. These are actually border zone or watershed infarcts. If there is hypoperfusion or hypotension, the proximal parts of the vessels get good blood supply, but as we go distally, the blood supply becomes sluggish, and at the distalmost part, there is cessation of blood supply. So, if there is a decreased blood flow due to hypoperfusion or hypotension, the anterior cerebral artery and the middle cerebral artery, the proximal parts get good blood supply, but as they go distally, blood flow becomes sluggish, and at the distalmost end, there is cessation of blood flow, and an infarct develops between ACA and MCA, what you call as water zone infarct or watershed infarct or border zone infarct, transcortical motor aphasia. So the lesion is above the Broca's area and anterior to the Broca's area. So you call that as the transcortical motor aphasia. It is very distal to the arcuate fasciculus, indirectly implying that the repetition is intact. So transcortical motor aphasia is like Broca's aphasia, but repetition is intact. Likewise, we have transcortical sensory aphasia, which is inferior and posterior to the Wernicke's area. It is between the middle cerebral artery and the posterior cerebral artery. The proximal parts get good blood supply, but as they go distally, there is a sluggish blood flow, and at the distalmost end, there is cessation of the blood flow. So this you call as a transcortical sensory aphasia. So transcortical sensory aphasia is like Wernicke's aphasia, but repetition is intact, because transcortical motor aphasia and transcortical aphasias, when they are present, it indirectly implies that the lesions are very distal to the arcuate fasciculus, and therefore the arcuate fasciculus is intact. That means repetition is intact. These are otherwise known as repetition sparing aphasias. When both transcortical motor and transcortical sensory and as well the Broca's and Wernicke's area, everything is affected, we call that as the global aphasia. Global aphasia represents a combined dysfunction of Wernicke's area and Broca's area, and it usually results from strokes that involve the entire NCA distribution in the left hemisphere. So Wernicke's area and Broca's area is affected, including the arcuate fasciculus. So they cannot understand, they cannot they cannot speak fluently, and they may not be able to repeat also. Anomic aphasia. This form of aphasia may be considered as minimal dysfunction syndrome of the language network. Articulation, comprehension and repetition are intact, but confrontation, naming, word finding and spelling are impaired. The lesion site may be anywhere in the left hemisphere language network, including the middle and inferior temporal gyrus. Anomic aphasia is a single most common language disturbance seen in head trauma, metabolic encephalopathy and Alzheimer's disease. For example, if we ask what is this, they may not be able to tell this is mobile, this is a cell phone. They'll be telling all the uses of the cell phone, like say this is used for calling up your friends. You can watch movies. You can watch movies. You can use it for other purposes also. They'll beat around the bush. They'll tell all the uses of the cell phone. There is known as circumlocution, but they're not able to name the particular instrument or the particular equipment which they have in front. So this is known as anomia, a deficit in naming. They may be able to tell all the functions of it, but they'll not be able to name it. This is known as anomia, which is a single most common presentation in aphasic patients. Pure word deafness. The most common causes are either bilateral or left-sided MCA strokes affecting the superior temporal gyrus. The net effect of the underlying lesion is to interrupt the flow of information from the auditory association area to the language network. Because of auditory information cannot be conveyed to the language network, it cannot be decoded into neural word representations, and the patient reacts to speech as if it were in an alien language that cannot be deciphered. Patients have no difficulty in understanding the written language and can express themselves as well in spoken or written language. Here, there's a disconnection between the auditory information center and the language network. So, when a person speaks, they'll not be able to understand, because there's a disconnection between the person's speech and the Wernicke's area, the auditory and the Wernicke's area, where it is necessary for comprehension of the spoken speech. So, someone speaks to them, They appear as if someone is speaking an alien language. They'll be just watching like that. But if you test other functions of language like spoken or written language, they'll be able to perform. So this is known as pure word deafness, a kind of disconnection syndrome. Like pure word deafness, we have pure alexia without agraphia. Alexia means difficulty in reading, agraphia means difficulty in writing. So pure alexia without agraphia, they have difficulty in reading but they don't have difficulty in writing. So they can write but they cannot read what they have just written. Very fascinating concept, pure alexia without agraphia. To understand this, we need to understand the principle. The language areas are on the left hemisphere for almost all the right-handers. So to convert anything into language area, we need to access the language areas which are on the left side. For example, I see on the right side, I want to convert the vision I see on the right side into a language form. So the right side of the vision goes to my left occipital cortex. The language areas are also on the left side. So I can easily convert whatever I see on the right side into a language form easily. But when I see on the left side, it goes to my right occipital cortex. But my language areas are on the left side, not on the right side. So it has to cross the corpus callosum and then access the language areas on the left side. So to convert anything on the left side into language form, it is slightly difficult and we need corpus callosum. So this is the principle. If we know this principle, understanding pure alexia without agraphia isn't difficult. So pure alexia without agraphia is a visual equivalent of pure word deafness. The lesion usually a combination of damage to the left occipital cortex and to posterior septum of the corpus callosum, the sphenium, interrupt the flow of visual information into the language network. The patient acts as if illiterate when asked to read even the simplest sentence because the visual information from the written words presented to the intact left visual hemifield cannot reach the language network. However, they have no problems in writing, which may access the language network traveling anteriorly. Even blind people can write. They don't need occipital lobe. The most common etiology is the left posterior cerebral artery vascular lesion affecting the left occipital cortex and crossing fibers of the sphenium of the corpus callosum. So when there's a lesion of the posterior cerebral artery affecting the left occipital cortex, when there's a left posterior cerebral artery lesion, it affects not only the left occipital cortex but the sphenium of the corpus callosum also. So in a person having left posterior cerebral artery lesion, the left occipital cortex is affected, so they cannot see anything on the right side because of right homonymous hemianopia. So they have to use the right occipital cortex. So they see things on the left side, they use the right occipital cortex. But whatever they see from the right occipital cortex, they cannot convert it into a language form because the language area is on the left side. So it has to travel from the right occipital cord to the language area. But the sphenium of the corpus callosum, which transmits the information from the right occipital cortex to the language areas which are on the left side, are affected. So they cannot convert it into a language form. They don't have problems in writing because it goes anteriorly. So these are the people who have pure alexia without agraphia. They have difficulty in reading, but they don't have difficulty in writing. They can write, but what they've just written, they cannot read. Very fascinating. Pure alexia without agraphia. Writing is very easy. You don't even need occipital lobe. Even blind people can write. And therefore, the writing part is not affected, only the reading part is affected. And second thing, the writing part goes anteriorly to the sphenium of the corpus callosum. So, alexia without agraphia is seen in left PCA infarcts. But if the angular gyrus is affected of the dominant parietal cortex, it can affect both reading and writing, which is known as alexia with agraphia. These are the components of Gerstmann syndrome. These are all the interesting components of the language examination which I've just discussed. I've enjoyed giving the lecture. I hope you have also enjoyed listening to my lecture. If you have any suggestions or comments, kindly post onto my YouTube channel, Dr. Sreenivas Medical Concepts. But please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts. And all the important points of neurology I put in a question answer format in a book, Focused Neurology, written by me, S. Sreenivas. It is available online from all leading booksellers, including Amazon. If you are interested, you can book it online. But please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.